Let's do it. Hi guys, welcome back to my channel. Happy 2024 to you all. It's gonna be an awesome year. Of course, I'm late in the game, but hey, this is my first video in 2024. If you're new here, welcome to the family. My name is Dr. Frederick Acquah. I'm an internist in New Jersey. I do both primary care and hospital medicine. This video will show you what my morning routine typically looks like, on the days that I come to the clinic. I hope you enjoy this video. Let's go. After a few years, I've realized that my circadian rhythm is similar to that of my middle child. Early to bed, early to rise, early bird gets the worm, that saying. So if I stay home to continue my morning routine after what you've seen before, as to doing a patient chart review can become a problem, because when he wakes up, he wants all the attention he can have before he gets ready for school. So what I do here is, instead of staying home to get work done, I bring it to work and make sure that I can complete things before 8:30. 8:30 is usually when I see my first patient. Schedule here between Monday through Thursday is 8:30 to 5 p.m. So when I come in, I log on to the computer system. There are two main windows that I have to open. Epic software, that's what we use in our clinic. So this is where I could see the patients that I have for the day. And then there is a Google Chrome tab where I check the emails that I have. And there are some additional tabs that I open, which makes my work efficient. So let's go straight to the tabs. So the first tab I open here is Up to Date. Up to Date. So when Up to Date open, this is what it looks like. It has the search Up to Date. So whatever question or whatever medical topic you have, you place it in there and you can do some quick review. I opened this because I realized that the human brain cannot contain everything. I cannot know everything in medicine. Medical school training, 4 years, you go through residency, you still cannot know everything. Of course, the common stuff you would know, and it may come to memory while you're in the room with the patient. But sometimes when you come in, a patient may be coming for something that you may have forgotten, a bit of it, so you may have to do some brush up. So this is where Up to Date comes in handy. So I go on Up to Date, search whatever complaint my patient has, and then see if I can generate or come up with a plan even before I go in and see the patient. So first tab here, Up to Date. The next tab here I have is Hippocrates. I like Hippocrates, because this is where medication help also comes into play. For every medication that you order for your patient, it's your responsibility as the physician or the doctor or the provider to let the patient know the side effect to expect. Are there any drug-drug interactions? Because some of the patients that I see here are above 65. They may not necessarily be on one medication. They may be on 2 or 3. Some of them are undergoing chemo. What medication I'm going to add, would it have an interaction with what they are on? So there are certain things that, like I said, I don't know everything, and I'm humble enough to say that, so it's better off for me to look it up than making a guess and the patient getting hurt later on. I don't want that happening to my patient, so I look things up. In New Jersey, there is a drug monitoring board, drug monitoring program, New Jersey Prescription Monitoring Program, so NJPMP. So for patients that we put on controlled substances, there's the website. You go, you plug the patient's information in there. So wherever that the patient has received controlled substances will show up in the New Jersey Drug Monitoring Program. So at least if the patient is going to a different city, let's say Hackensack, and getting a Percocet, maybe it was filled 2 weeks ago for a 30-day supply. The patient may come here in Toms River and say that, hey, I want to be a new patient. I'm in pain. I need Percocet. But when I go here, I'll see that the patient received something 2 weeks ago that should have lasted for 30 days. So we don't keep prescribing controlled substances to our patients. They can become addicted and people can die from them. The next one here is MedCalc. So with MedCalc, I think the main thing I use it for here is if I have a patient on statin therapy. This is a cholesterol medication. So new patients come in, do blood work, their cholesterol numbers may be all over the place, right? So this is the case that we try lifestyle modification for, 3 months. Patient may come back, they want to repeat the lipid panel, repeat it, but the numbers may still be deranged. So this is where I use evidence to prove to the patient that they have to be on cholesterol medication. What do I mean? So here, example, I can search ASCVD, which is the atherosclerotic cardiovascular risk. What is your risk of getting a heart attack or a stroke based on your cholesterol profile if I don't put you on medication? So if I plug in those numbers, first of all, do they have a history of heart attacks, peripheral vascular disease, stroke or mini stroke? We call it TIA, transient ischemic attack. If yes, then it's an automatic statin therapy. We put you on that medication, right? The next will be your bad cholesterol, LDL. If it's above 190, I put you on cholesterol medication no matter what. And it's a high intensity statin therapy. Now, if not, this is where we go into the patient's age, the cholesterol, the good cholesterol, HDL, if the person is a smoker, if the person has high blood pressure, if the person is a male or a female, we put all that information in there and it comes up with a risk score, right? Their risk of getting a stroke or a heart attack. And based on that, I show it to the patient and, hey, this is your risk, but as your primary care physician, I encourage that you be on a cholesterol medication. It's always the patient's choice at the end. You can bring the horse to the water, but you cannot force the horse to drink that water. I can give the patient the statin therapy, the cholesterol medication. They may go home and just toss it in the garbage. I do myself no good. I don't want to treat myself, by just giving it and feeling good. I want to make sure that myself and my patient, we have an agreement and we can work on something together. All right, since I work with residents here, there is MixApp 2019. I have an account, so we can work on questions sometimes if we have a downtime. If not, and there are certain topics, I can give it to the residents to read on and then we discuss at a later time. All right, so the next one here is there's Google. So I add Google to it because some patients are audiovisual, okay? So when they come in with a complaint, let's say they have pain in the belly. Oh, my belly hurt. Which part? Oh, the right side. Oh, sometimes it goes to the flank, the side. Oh, it gets to my back too. I feel like it's moving down to my groin, right? So this tells me that, sure, patient may be having this kind of complaint. So I open up the anatomy of the abdominal system, right? So then I explain to the patient the different quadrants, and if it's in that right upper quadrant, what are the things that I'm thinking of, or what are the organs that may be affected, right? So this is where I go through with the patient. Sure, it could be the biliary system, the gallbladder, is it the liver? Is it the kidneys? Do you have a stone? You know, if it's a female patient, then if it's on a lower part, we consider their gynecological systems, you know. So they're showing patients the pictures does help. You know, we went to school, medical school, we learned all these things. You know, in the real world, you need to break things down to the patient's understanding. Otherwise, patients come in and using big terms, big words, they don't get anything from you. There is no benefit. You know, you always need to break things down to the patient's understanding. So sometimes I ask their level of education to see how much information they can, you know, absorb during the visit. If not, we give them information when you're leaving and they can read more on that. So these are the tabs I open on my Google Chrome on one of the windows that I have when I come in the morning, and that helps me with efficiency, getting through and seeing or getting ready for my patients. All right, so the next one here is Epic software. So this is where I see the patients I'll be having for the day. And there's something called an in-basket. So in-basket is how you get to communicate with some of the medical staff or the lab, whatever it is. So here today, I see I have 42 new messages in my basket to go through. So what are the things that I can see here? So here I see results. So there are 15 results in here. So there were patients that I saw who did blood work. The blood work results are back. So I have to make sure that I look through them. So usually what I do is I scan through them. I see which ones are abnormal, you know, that which ones that I'm concerned about. And then I get to call the patient and then discuss with the patient what I found and what we could do about it. We also get help with the medical staff in office. So in case everything comes back normal, sometimes I give it to them if they have less on your table. I know they have a lot doing, you know, and then they get to make the phone call on my behalf. But other than that, I do my best to call all my patients when I have a downtime during the day. So here I have 15 new results that I need to call the patients for and discuss. The next one is prescription request. So this is where patients are running out of medication and they need a refill. They send it through, I see it, and I give them the refill if they don't need an office visit. There are some medications that our patients are on that they need to be coming to the office every month, especially controlled substances, or let's say every 3 months, you know, blood pressure, diabetic patients, you know, so I need to see which one that is. Patient calls. So most likely being off on the Friday, there was a patient that may have called. Based on how urgent it is, if it's urgent, they sometimes call me on the phone and then I check the chart, call the patient. If not, then I get to call the next day. Hospital ADT. So this is usually a patient that went to the emergency room or was admitted at a hospital, but the patient does not have a primary care physician. So when you're getting discharged, I get a link to go into the patient's chart to see what they came to the hospital or emergency department for, and then what I can glean behind their history before I even see them in the office. Or if my inpatients go to the hospital or the emergency room and they get discharged, I get a copy of what they went in with, what was done, so at least I'm also aware of what's going on with my patients. The next one here is CC charts. So let's say that I refer the patient to a specialist who is also using the Epic software. When they write a note and they CC me, it comes in my in-basket and I see what they did during that visit. Also CC'd results, same idea. These subspecialists ordered something and I get CC'd on it, so I also see the results. Coding query. So maybe a patient came in, I may have undercoded or overcoded the patient. Coded meaning that they came in with an issue and I, let's say, put in a CPT code, right? And then with that CPT code, maybe the insurance are saying that they may not pay for it. I may have to change 1 or 2 things in my note for them to pay for that visit. So we have great people working to help us make sure that we get reimbursed with the work that we do. And then patient advice request. So a patient sent a message, they need an advice, so I have to go through and respond to them. Typically, this is what I do in the morning when I come here, and then 8 o'clock is usually the time where I call patients, let them know their lab results. Hopefully I'm not waking people up at odd hours, but I think at 8 o'clock you should be awake. Sometimes we leave a voicemail and then we try again, or they call the office and we call them during break time hours between 12 and 1. So like I said, morning starts 8:30, and then at 12 to 1 o'clock is lunch break, and then and then we end at 5 o'clock. And then after 5 o'clock, in case things happen, if I had a busy day, I get to stay later, go back to my in-basket, see what happened, results, patient prescription requests, and then we get to work on that. All right, so that's what I have for my morning, and I'm getting ready. I'll make a few phone calls and start seeing patients. Thank you for staying to the end of this video. If you're in the medical field, interested in medicine, I think you could still do it, irrespective of your age. As long as this right here is ready, as long as your mind is ready, you can achieve whatever you put to yourself, okay? So set higher goals and keep working on your craft until you get there. I know you guys can do it. I'm trusting that you got something from this. For medical students interested in primary care, this is what I do, and I love it. This is a dream come true, and I hope your dreams do come true one day. I'll see you in my next video. Shalom.